All right. Hello, everybody. Good morning. We'll give everybody just a minute to get all the way connected here. Good morning. I would love to know who is joining us on the call today. So if you have the ability and you want to open up the chat and just let me know who you are, what do you do? Are you a doctor, a PA, a pharmacist, a navigator? And where do you work? I just like to know where people come from across the country and sometimes around the world. We get a lot of really fun locations for attendees, and I love to know where everybody's from. And I just want to say thank you to all of you for being here this morning. If it's your first time coming to one of our Butte Basics, welcome. If it's not, then no worries, because we are going to actually review some things that are a little bit new this time. So every time you come back for the basics, hopefully we're adding another layer to your knowledge base. So thank you so much for being here. And let's get started. So I'm Alicia Gonzalez. I am the Director for Clinical Training for the California Bridge Program. I'm also an emergency physician, and I work in San Diego, California, and in Brawley, California, which is the rural healthcare community down south in our southernmost part of the state. And if you're not familiar with the California Bridge Program, we are a part of the Public Health Institute. We are funded by DHCS. We are a nonprofit organization, and I do not have any financial disclosures. Sometimes I might refer to buprenorphine as its brand name, its most common brand name, Suboxone, or naloxone or Narcan as the brand name, only because it's really familiar for our clinicians and for our patients. So it's not for any financial reasons, but I want to make sure everybody's able to follow along. We at California Bridge have a goal of making access to medication for addiction treatment, specifically buprenorphine for opioid use disorder, available at every single emergency department in California by 2025. And I'm very proud to say that we are well on our way. We are over 80, I think almost 90% of hospitals in California and counting. So every one of you being here, thank you so much for your presence and for the work that you're doing to help your hospital come along in this journey with us. Why do we care? Hopefully this is not news to you, but I think it's a really sobering reminder for all of us that people are still dying. People are still newly starting heroin, newly trying fentanyl, and these drugs are they're everywhere, and it really is still an epidemic that is killing a ton of people in our country. And so we want to save lives. The number one thing we want to do is help people live long, healthy, and happy lives. And really, there's no other better cause and no other better way to do that in 2023 than to take on the opioid epidemic. And if you're somebody who thought like, well, hey, listen, I thought the healthcare community, prescription drugs were our problem. We stopped doing that, so we're done. That's unfortunately not true. And that's what this graph is showing you. When the bottom purple bar started shrinking because we got smarter as a medical community, we stopped prescribing so many opioids. It didn't actually help the death toll. Look at that blue bar. The less we prescribe, purple bar shrinking, the more people are still dying from opioids. And that's because illicit drugs like fentanyl are everywhere. They are pervasive in our communities now across the country. And we can't make that stop by curbing our prescriptions for opioids. So we have to do something different. And that's where we come in. California Bridge, thinking about addiction as a chronic medical disease, something that we can treat with evidence-based medicine and moving away from this old stigma that we used to carry about how it was a moral failing, like, oh, bad people that made bad choices. That's just simply not the case. And we know that there's an overwhelming amount of neurocognitive data and research that proves this to us. We know that addiction in the mind is a lot like any other chronic disease. So let's take diabetes, for example. Sure, people make choices that lead them to develop diabetes. Maybe they don't diet and exercise appropriately. Maybe they're obese or they have a really elevated BMI, and that leads them to have issues with their insulin. So now we give them insulin, or we give them oral medications to help with, weight loss and with controlling their blood sugar. But we don't say, we're going to take this away from you because you ate donuts and you're a bad person. We would never do that, because we know that people are driven to eat foods that taste good by their dopamine center. Same thing with addiction. Once somebody has tried drugs, our brain very powerfully motivates us to seek out those drugs. But we have medicines. That's the good news. We have medicines to help people to control their addiction and to recover from their addiction. And that's really what we're looking at here, is moving away from bad people to just unfortunate choices with long-term consequences that we can help as medical professionals. And that is where the California Bridge model comes in. Number one, providing low barrier access to evidence-based medications for addiction treatment. Instead of saying, you just gotta struggle through it and get over it. We have medicines that can help people. We want to talk about that today. But the second piece is having a warm handoff, a connection to ongoing care. That is where all my navigators on this call and in our communities come in. And that is a person who, can speak in plain language to a patient who is struggling with addiction or substance use issues and connect them to ongoing care in the community. Our goal in the ER is to remain stabilizers, the acute treaters of a problem, somebody who helps in this moment when you need me, but I'm not the right long-term medical professional for you. And so we want our navigators to really help people navigate the complex system that is the outpatient addiction medicine world and get our patients into a stabilizing version of their care in the outpatient setting. And that takes the work of our navigators. So I want to applaud all of them. And then, of course, developing a culture of harm reduction, which is two pieces. One, decreasing that stigma we were just talking about so that we can have open conversations with our patients about drugs and help people live well, but also thinking about harm reduction as a way that we take care of patients. We can't make everybody stop doing drugs. So how do we help them live well and stay alive without HIV or Hep C or endocarditis or other severe diseases? Because you cannot enter a journey of recovery if you're not alive to do so. So we want to keep people alive and help them live as healthily as they can so that when they are ready for recovery, we are here for them. All right, let's dive into the meat of this presentation, which is going to be, I should say that, the protein of this presentation, which is going to be low barrier treatment. How do we start people on evidence-based medication for addiction treatment? And the medicine we're going to talk a lot about today is buprenorphine. But why do we think that medication is important? Well, we know that for the average person who is out there, let's say that your risk of death in the coming year is 1.0, just 1 is the risk of death in the year. If somebody is actively using opioids, their risk of death is 6 times higher than somebody who's not. That makes sense to me, right? That tracks. A lot of people are dying from opioids. It makes sense that that would really increase your risk of mortality. However, if we start somebody who uses opioids on methadone or buprenorphine, so on medication for their addiction, their risk of death comes down to less than 2 times, so nearer to the general population. This is a gigantic mortality reduction, gigantic. There are very few medicines out there that are this powerful at reducing mortality, which is really what our goal is. So it's super, super exciting that we have something that is that effective. And why is this something that should be in the emergency department or in the hospital, or that you're doing it in urgent care in that acute setting? We know that for patients who came into the hospital and overdosed, this is a study from the East Coast that was done a couple of years ago, that for patients who came in after an overdose, their risk of death over the next year was extremely high. That also makes sense, right? They literally just died and got naloxone or Narcan to wake themselves back up to live again. It makes sense that that person's risk of death would be very high for the next year. But of those patients who died over the next year, the vast majority died in the first month. And of that group, 20% of them died in the first 24 to 48 hours. So if you look at that graph on there, there's a giant blue spike on the very first 24-hour period. This is telling you that other people who overdosed, their highest risk of death is in the next 1 to 2 days. The highest, most vulnerable moment of their life is the next 24 to 48 hours. So for us in the emergency department, if somebody overdoses and comes to the ER or is in the hospital, you know that you are seeing that person at a time that is so medically vulnerable. This is the TIA or the DKA or the unstable chest pain, the NSTEMI of addiction is when somebody comes into you in the emergency department. So we have this critical moment where we can intervene and take that very seriously to save a life. So this is our problem. This is a resuscitation and a stabilization moment for us. I would be remiss if I did not mention that there are other medications that people can use, like methadone. Methadone is a full agonist opioid, and we are not here to knock methadone today. It's a really important medication. We are still starting lots of patients on methadone, and it can be, really safe and really important for some of those patients. So we're going to focus on buprenorphine for reasons I'll explain in a minute, but we don't want to get rid of methadone, and it will always have a really important place in the addiction medicine space, in the recovery space. Naltrexone is an antagonist, so it turns off your opioid receptor, and that is another medicine that is good for some people. It's a little bit more mechanistically difficult to get for some of our patients in the ER especially, which is why we're not going to focus on that medicine today. And the evidence is really just overwhelming for methadone and buprenorphine. But for buprenorphine specifically, we're going to focus on this medicine because of its very practical nature as a great medicine for the ER. It often comes mixed as buprenorphine naloxone, the idea being that the naloxone is sort of inert if you take it appropriately. So whether it's mixed or not, let's just focus on the buprenorphine, which is the medicine that's working. It comes as a dissolvable tablet or a buccal mucosa film, like those old breath mint strips that people would use that melt in your mouth. It does have to be absorbed orally. So unlike some medicines like ondansetron for vomiting, where if you swallow it, it still works, buprenorphine actually does have to be orally absorbed. So nothing to eat or drink for about 15 or 20 minutes afterward, but it's an absorbable medication. It also comes in IV and intramuscular forms, but we're going to focus on the oral dissolvable. And we like it because it's a partial agonist. So it only turns that mu receptor halfway on, enough to take somebody from withdrawal to feeling normal, but not to cause super high euphoria the same way that a full agonist like heroin, fentanyl, methadone, morphine, etc. would do. Because of that only partial agonistic effects, it has a respiratory ceiling, meaning it, even at very, very high doses, which there is no maximum dose technically of buprenorphine for this purpose, but even at very high doses, it's not going to cause respiratory depression. It's super safe. So you can imagine that is a giant win, right? High doses of methadone would cause overdose, but not high doses of buprenorphine by itself. If you mix it with other respiratory depressants, sure, that could happen. But bup alone, it would be extremely difficult, even at really high doses, for somebody to overdose on buprenorphine. It's also got a really, really strong affinity for that mu receptor. So if somebody has, bup in their system and it's holding on to that opioid receptor, even if they relapse and say take an oxy or they inject fentanyl, the fentanyl is not going to displace the buprenorphine off the receptor. So in some ways, there's like this airway protection, and that if the bup is there, it's going to hold on there, and the bup is safer than the full agonist opioid that they might choose to use on top of that. So we love that, and it lasts for 24 to 36 hours with a half-life. So it can be a once-a-day dose. People can separate it out to take it multiple times a day. That's fine, but it's really a practical medicine. We can start it right here in the ER. Has a pretty quick onset. It's very, very safe, and so patients can go home with a prescription for it instead of having to go to a treatment center every single day, which is a win for them as well, and it helps take away some of their barriers to access care. So hopefully it's obvious why, we like that medication. It's just really practical and it works for us and it's safe. Why should we start it though in the ER? Why can't we just say, hey, go to clinic and here's your, prescription to go pick up your medicine? Well, there was an amazing landmark study done by Gail D'Onofrio and her team that showed that of the patients who came into the ER in opioid withdrawal, for those who got buprenorphine right away and then got really close follow-up versus those who just got really close follow-up, the number of patients that stayed in treatment at 6 months was 78% for those who started medicine now. So they all got the same services, the same warm handoff, the same close outpatient follow-up. But if they started medicine now, if we help them feel better now, we relieve pain and suffering now, it doubles their likelihood of staying in treatment at 6 months. And I already showed you that being in treatment saves lives. So that means that starting medication in the ED literally saves lives. So it's such an easy, overwhelming thing, evidence-based to do. And this will show you for a bunch of things that we consider standard of care in emergency medicine, that the number of people needed to treat to be successful in saving a life is only 2. So there's no reason not to do it. It obviously works. And I am so excited right now to show you the California Bridge Buprenorphine Quick Start Guide. So we have had this as like our number 1 most used resource, and we recently updated it, and I'm really excited to show you what that looks like based on a lot of feedback from our experts and our providers. So let's walk it through. First, you need to identify a patient who is in opioid withdrawal. If you know what that looks like because you're a trained clinician and you're comfortable with that, done. Patient has to be in moderate to severe withdrawal. I walk in, I say, that looks like withdrawal. They say I'm in withdrawal. We're finished. But if you're not comfortable, you can always use the clinical opioid withdrawal scale, or COWS, to help you. It's not an evidence-based, peer-reviewed scale. It's not like CWA for, benzodiazepines for alcohol withdrawal. This is just a way to help you if you're less comfortable, figure out if somebody's in moderate to severe withdrawal. So feel free to use a COWS if you need to, but you don't need to. And once you've said that, hey, that person really is in withdrawal, and I mean withdrawal like with at least 2 objective findings. So we want to make sure that we've got hard signs, things you can see: tachycardia, dilated pupils, runny nose. Are they vomiting? Did they go to the bathroom 4 times because they're having diarrhea? Do they have the goosebumps? Are they kind of getting fidgety? Are they agitated? Are they sweaty? Things you can see. And the reason is that we don't want to precipitate withdrawal, which we'll talk about in a little bit. But really, they have to be in moderate to severe withdrawal. You're seeing objective findings. You feel comfortable that that's where we're at. They are ready or interested in at least trying buprenorphine. And you want to make sure that they don't have any contraindications. There aren't that many, but obviously we don't want to give buprenorphine to somebody who is, say, altered. People have to be awake enough to talk to you about it. And if somebody's here for a different reason, like maybe they were in a car accident and they happen to also be in withdrawal and they have a big femur fracture, today may not be the best moment to start them on their road to recovery. Like, let's focus on the femur fracture, right? And we can take care of that later. So really, it has to be not in the middle of some other severe medical illness. You're not resuscitating a trauma, et cetera. And you definitely don't want the patient to be somebody who is currently actively taking methadone, because methadone has a very long half-life, and we don't want to accidentally precipitate withdrawal. So if the person is in moderate to severe withdrawal, they're interested in starting bupe. You'll notice I did not say interested in entering long-term recovery. That's fine. They don't have to. Bupe also relieves pain and suffering from withdrawal. So we're hoping this person enters recovery, but they don't have to commit to that. So don't make them. Just try to get them feeling better now. That opens the door for a better conversation about recovery, right? So we are going to give 16 milligrams or more of buprenorphine, sublingual or buccal, depending on the formulation your hospital has, and let that dissolve. Again, nothing to eat or drink for 15 or 20 minutes. You'll notice that the range goes from 8 to 24 milligrams. So some patients who are, say, only using maybe a handful of pills a day, like if people take oxycodone or hydrocodone, they might be able to get away with an 8 milligram dose. The vast majority of patients now, because fentanyl is so pervasive in all the drugs, M30s, et cetera, that are being done, we recommend starting with 16 milligrams. For patients with a heavier use pattern, and you're not sure what that means, ask the patient, would you consider yourself like a low level, middle level, high level use? What do you think? And if they say, oh, it's pretty high, it's pretty heavy, you inject fentanyl multiple times a day, don't be afraid of going even higher, 24 milligrams. Some of us even have given 32 milligrams, depending on the patient. So do not be afraid of the high dose. You will notice there is no low dose on here. So don't get yourself caught in a mess by doing 2 or 4, little milligram doses. Please give 16 milligrams up front, maybe a little bit more, and then you're going to wait for a little bit. Make sure the patient has not had methadone. That's the main thing. If they take other respiratory depressants, alcohol, benzodiazepines, they're using like Xanny bars or whatever, that does not mean that you cannot start buprenorphine. So please don't panic. It's okay. They're doing something far more dangerous in their daily life by taking, say, a benzodiazepine and alcohol and fentanyl. You are not going to do something more dangerous by giving them a partial agonist, which is buprenorphine. But maybe this patient shouldn't be in the lobby. We want them maybe on a pulse ox, just a little bit more monitoring than the average patient starting buprenorphine. So make sure they're not on methadone. Think about whether or not they're using other respiratory suppressants. Do they need a little bit more monitoring? Start them on 16 milligrams of buprenorphine. And then if, again, they have a very high use pattern, they're a frequent fentanyl use kind of patient, then we might get even more. You're going to wait 30 to 45 minutes. We used to say an hour, but the truth is that we will start to see effects a little bit earlier than that. So 30 to 45 minutes, reassess your patient. If they're getting better, awesome. Give them some more. Give another 8 to 16 milligrams, even 24, depending again on the patient. There's a little bit of art to this. There's no perfect graph, but you kind of get used to it over time. But don't be afraid of those 16 milligram doses. Give your patient another dose of buprenorphine. If the patient is not getting better at all, then take a step back and think about if you're missing something. Most patients who are in pure opioid withdrawal will get better with more buprenorphine. And the most common reason that people aren't getting better is that we didn't give enough buprenorphine. So as patients continue on the continuum, if you will, they're moving along the withdrawal road, they're going to keep getting sicker and sicker. That's what withdrawal looks like. And if you give them a tiny little friendly dose of buprenorphine that was not enough to saturate their receptors, it did nothing to them, and they're just going to get sicker over time. Okay, so think in your head, did I really underdose this patient? Did I give 4 milligrams, which hopefully you never did because you watched this lecture, but did I give 8 milligrams? Did I give 16? But it turns out that their usage pattern is really heavy and they need a lot more than that. So number one thing is undertreated withdrawal. So think about giving a lot more, but also think to yourself, is this DKA? Is it a viral syndrome? Is it sepsis? Is it something else? So just don't be afraid to think about alcohol withdrawal. What other thing could it be? I still recommend giving more buprenorphine, but maybe you add some labs at this point, or maybe you do a different history. But again, number one, most common reason, undertreated withdrawal. Not to be confused with everybody's favorite thing to talk about, which is precipitated withdrawal, which is like a bad P word that everyone is so scared of. And it's like the #1 barrier to why clinicians these days don't want to start buprenorphine. So let me myth bust here for a second, which is that precipitated withdrawal is not common. It just isn't. It is not common. Undertreated withdrawal is super common. So that's the first thing. Undertreated withdrawal means not enough buprenorphine and withdrawal just keeps on progressing. Precipitated withdrawal means patient has a lot of full agonists in their system. You gave too little buprenorphine or not enough buprenorphine too soon. They weren't in moderate to severe withdrawal, and you now plummeted them down. So we want to go from withdrawal to feeling better, not I still have fentanyl in my system, got buprenorphine, got pulled down to a partial agonist because that bup kicked off the fentanyl or the heroin or whatever from that receptor. That's what we're trying to avoid. It is not something to be afraid of because we do it all the time on purpose. It's what happens when we give naloxone to somebody who overdosed. That is a precipitated withdrawal. So it's not the same thing, but it is going to happen sometimes. And I think we keep talking about it because people don't want to break trust with their patients. They don't want to make them feel sicker. They don't want to lose this opportunity to make them feel better. And so one of the ways to address that is to be upfront with your patient about it at the beginning. Think about starting a patient on buprenorphine as a procedure, a very, very safe procedure, but a procedure. You would never just start a patient on, a blood thinner and never explain to them how it works, or insulin and not explain to them how it works. So it's kind of the same thing. You're going to tell your patient, listen, I have some medication that's going to make you feel better. It's not instant. It's not a magic wand, but in like an hour or two, you are going to feel so much better than you do now. And it might need more than one dose. Okay. But I'm here with you. I'm not going to abandon you. I'm going to be here with you all the way. I'm going to set this timer on my phone. I'm going to check in on you in 30 minutes. And if you're not getting better, I'll give you more medicine. I can't make your withdrawal go away like this, but it's going to be the best withdrawal you've ever had in your life. Like, we're going to get there together, you and me. We're going to get there. And if something bad happens, like precipitated withdrawal, I'll be here for you. And I have medicines for that. And I can make you feel better because you can. Because if somebody precipitates withdrawal, the answer is to give buprenorphine. And more buprenorphine and more buprenorphine to saturate enough of those receptors to now pull them out of the actual withdrawal. How do you treat precipitated withdrawal beyond that? So let's say you give a patient who had maybe a heavier fentanyl use pattern. Fentanyl diffuses in their adipose tissue and even into their muscles if they have enough fentanyl in their system. You think that they're in moderate to severe withdrawal. It turns out they have a heavier use than you thought. You give 16 milligrams. It's not enough. The patient precipitates withdrawal. Maybe they use that morning. Who knows? What do? You immediately give another 16 milligrams of buprenorphine. If the patient has, again, a really high usage pattern, don't be afraid to give even more, 24, 32, etc. So you're going to give at least 16 milligrams of buprenorphine. And we recommend a single dose of a benzodiazepine. Ideally, 2 milligrams of lorazepam is a really good choice. You can do that PO, or if the patient now has a bed and an IV, you can do that IV. We also recommend not forgetting all the other medicines that we have used in the past to help people feel better. So use your antiemetics, stop the vomiting. You can use, NSAIDs or acetaminophen for pain. You can use antipsychotic meds like olanzapine or even like haloperidol to help with some of that like non-nociceptive pain that's going on for people. You can use all kinds of medications. So just think about all the other meds that aren't opioids that can make people feel better. Don't be afraid to add a dose of lorazepam. Give more buprenorphine, and some of our experts even recommend trying ketamine. As a worst ditch effort, you've done all of that, nothing is getting better. You can consider giving high doses of fentanyl just to pull yourself out of this moment, and that can be successful as well. So this is a part of our quick guide. You can look at it in more detail later. We also have separate lectures dedicated to precipitated withdrawal if you need more info on that. And so those who are asking, that is a part of the quick start guide. That's in the middle of our quick start guide, that precipitated withdrawal information. Then what do? You discharge the patient with medication. We want them to stay on it. So don't be afraid to give them a prescription for this. This is safer than any of the other opioids that you are writing for patients. So don't be afraid to do that. We want patients to stay on their maintenance buprenorphine one or two doses a day. Once a day is enough to cover withdrawal, but some patients will prefer to take their medicines in 2 or 3 times a day dosing, like split it up. So let's say you're going to send them home on 32 milligrams a day. You can divide that up into 16 milligrams twice a day. You could do 8 milligrams 4 times a day. It doesn't really matter. The rise and fall of the pain effects, the analgesic effects of buprenorphine are more short-lived. So some patients like to take them a little bit more frequently, whereas the withdrawal coverage is really long, is like 24 to 36 hours. So you can take, the total daily dosing, as long as they get that in 24 hours, they will not re-enter withdrawal. Use what your patient's preferences are to help kind of drive how you write that prescription. Most patients will be good on somewhere between 16 to 32 milligrams a day, even if you had to go a lot higher than that physically in the ED to get them feeling better. That initial buprenorphine load is can be a lot higher than what they need to be on for maintenance. So you can always send them home on about 16 or 32. I always write for some extra, and I tell them if you're still in a lot of withdrawal, you take an extra strip. Remember, there's not going to be respiratory depression just from this medication, so it is safe for them. And you want to make sure you're giving them enough of a supply to get through to their actual follow-up visit. And what I would say is pretend they're going to miss the first one, because all kinds of reasons happen. Transportation, clinics cancel their day because the doctor got sick, whatever. So if you know that the average length of time to get follow-up is 2 weeks, then I say write for 3 weeks, and make sure that they know they can come back to the ER and get some more medicine if they run out. You'll notice we did not mention an X-Waiver. There isn't one. If you think you have one from before, you don't. They're just gone. They're not necessary. Any clinician with a DEA license that does, so if you can write for Norco or hydrocodone, you can write for buprenorphine, period. End of story. Everyone can do this. There are now some DEA education requirements for all of us. And if you need help meeting those, we have a California Bridge Free CME Academy that you can use to meet that requirement. But as of right now today, if you have a DEA, you can do it. And also big news, as of January 1st, thanks to our friends over at California ASAP, you will not have to check cures, even if you're writing a multiple week-long prescription for buprenorphine, because this is different. This is not a pain medicine. I don't care if somebody just filled a hydrocodone prescription 3 days ago. I'm starting them on treatment. Not going to change my mind. So as of January 1, there's no need for a cures check in California. For those out of California, that's a California specific law. But the X-Waiver is national. Nobody needs one of those. If you're on shift and trying to do this and you need help, please feel free to call either the Poison Control Center. Remember that they have some experts and they use our materials that can help walk you through it. And then also you can call the clinician consult line, which is run out of UCSF. That's a warm line. They're not there all the time, but when you can get them, they're super helpful. It's a really good resource for like inpatient doctors who are trying to manage pain and in some of those more complex patients. So let's just break it down to the quick and dirty version. What did we just learn? Your patient is in moderate to severe withdrawal. They want to try buprenorphine. They're not, actively taking methadone, and you're not, they're not in a medical emergency. Give them at least 16 milligrams of buprenorphine, maybe a little bit higher, maybe 24. And then you're going to wait 30 to 45 minutes. If your patient's feeling better, wonderful, give them another dose to complete that loading dose. If they're not feeling better at all, still give more, but take a step back. What are you missing? Is there something else in the differential you need to consider? Then once they're feeling amazing and better, we're going to let them go home with a prescription for buprenorphine divided into like somewhere between 1 and 3 times a day dosing, depending on patient preference, that covers them for somewhere between 16 and 32 total milligrams per day. Give them enough tablets or strips in that prescription to be able to make it to their follow-up appointment, and some extra in case you accidentally underdose them, they need extra, etc. What if they want to start treatment, but they're not? What if they're not in moderate to severe withdrawal? That's okay. Patients can actually self-start on buprenorphine. We have this handout on our website in English, Spanish, Vietnamese, a couple of dialects of Chinese language, and some others. So you can give your patient a self-start prescription, and we do have that algorithm available on our website. Totally safe to do. Turns out patients are very good at knowing what moderate to severe withdrawal looks like. They can understand when you say, hey, wait, so you're like an 8 out of 10 kicking it. Don't start too soon. And they'll understand that, which is really cool. If your patient is pregnant, it is absolutely safe. And not only is it safe, it is recommended by the American College of Obstetrics and Gynecology to start patients on MAT. That includes buprenorphine. Plain buprenorphine or combo buprenorphine naloxone tablets, doesn't matter. Both are very safe. They're also safe in breastfeeding, so moms don't have to stop being in treatment when they have their baby. You do not have to start patients on a baby monitor, even in their 3rd trimester. You do not have to admit them to the hospital. They are just like every other patient. It can be done from the ER. Please don't overcomplicate it. That just kind of adds to the stigma and the frustration. But moms who are in their 3rd trimester do have a bigger BMI than they're used to, and they might have to go up on their dosing. So just be aware of that. And then finally, oh, that's right. they do have lower rates of neonatal opioid withdrawal syndrome or neonatal abstinence syndrome, whichever terminology you're using. So it's good. It's good for mom. It's good for baby. It saves 2 lives. Do it. What if your patient is on buprenorphine and they come into the ER in pain? Now they broke their arm or they're admitted for cellulitis or something like that. We have a full algorithm that I invite you to go look at on the California Bridge website. However, the overall take-home point is do not stop their buprenorphine. Buprenorphine does have a analgesic effect to it in shorter intervals, kind of like a 4 to 6 hour rise and fall. So you can take somebody's total daily buprenorphine. Let's say that they take 24 milligrams a day. You can divide that into multiple doses, multiple smaller doses, and give that same amount over 24 hours in smaller doses. You can then take that smaller dose and go up if you want. So let's say you have them on 4 milligrams 4 times a day. You can go to 8 milligrams 4 times a day. You can also use all the non-opioid medicines that we use for pain, and we encourage that. And if someone's in really severe pain from, let's say, trauma or something like that, you can always add full agonist opioids on top. Remember, the buprenorphine will hold on to the receptor. So you can add opioid on top, but don't take the bupe away. It'll make it so much harder to treat the patient's pain, so much harder, and it'll be harder to keep them in recovery afterward. When should your patient stop buprenorphine? They shouldn't, is the short version. We don't say, when is this patient going to come off of insulin? When is that patient going to come off of albuterol? When is that patient going to stop needing antihypertensive or cholesterol medicines? No, those are chronic medications treating chronic diseases. Will some patients with cholesterol issues get off their statin? Yeah. Will some patients who are on insulin lose weight and get their diet cleaned up and then not need it anymore? Yeah. Will some patients who are on buprenorphine not need it forever? Yes. But what we know is that overall, when you make patients taper off or you force them to come off, their rates of death skyrise. They're so high. It's really dangerous and it's not okay. So we are trying to help people stabilize their brain chemistry because their brain has a dependence on at least having some low-level opioid in there. We do not want to take that away. We want to help them keep that chemical homeostasis so that they can live well. So that's not the focus. We don't want to focus on that. There shouldn't be such a thing as a requirement to taper off or come off in any clinic setting. That's probably a different conversation. But for any of us in acute care, the conversation with your patient is, we're not talking about coming off of the medicine right now. We're talking about getting on the medicine. Let's just get better. And then you can work that out later. Let's treat this like a chronic disease and get you stabilized, and we can deal with the rest later. I want to make a quick comment, a couple of tips about harm reduction in case it's a newer concept to you. And the idea is, not every patient is going to not do drugs, and that's okay. People have agency. They can make choices. Diabetics eat donuts. People with asthma forget their inhaler. Patients with substance use disorder use drugs. And I'm not saying that we are condoning that. I'm just saying we want to support people to stay healthy through the choices that they are making, because that is our job as medical professionals. Again, you cannot be in recovery if you're not alive. And I don't want my patients getting sick and getting HIV, et cetera. So fentanyl test strips have come a long way. We have a full FAQ on how does that work on our website. If you're not familiar with them, take a look. They're not a perfect tool, but they're better than nothing. And they are becoming more available out there in the community. So that is one option for patients who are, say, trying to use a stimulant like methamphetamine or cocaine, and they're worried about overdose. They can use fentanyl test strips to test their product before using that drug. Naloxone, if you are not handing it out, giving these cute little boxes to your patients, please see our naloxone distribution guide on the website and set up a program where your patients take it with them. We know that nationally, the fill rate on a prescription for naloxone is like 1 to 2%. Horrible. No one fills that prescription. And yeah, it's over the counter, but patients time and time again tell us stories about experiencing stigma when they go to the pharmacy to get it. So they just don't want to do it. So we want to make it really, really easy to get naloxone out there. I know there are some people nationally working on making this a reimbursable service. So hopefully it will become a sustainable program in any state that you're in. For those in California, there is a program from the state that is free for your hospital to hand out naloxone. So reach out to us if you want help doing that, but we want naloxone everywhere in the community. It's the AED of 2023. If you can't do any of that, at least coach your patients about not using drugs all by themselves, because that's when overdose and death happen, especially when no one's there to call emergency services. There is a national hotline, the Never Use Alone hotline. It's anonymous, it's free. Patients can call this number when they're using drugs. And then if they become unresponsive, the staff will send EMS personnel to the location of the patient to bring naloxone and resuscitate them. So it's a really helpful thing. I actually ask my patients in real time in front of me to save this number and mark it as a favorite, as just like a backup plan, so they're not using alone. And then we have a lot of tips about how do you actually safely use drugs. I don't want people to inject drugs, but if they're going to, I really don't want them to get HIV, Hep C, endocarditis, abscesses, etc. And so the National Harm Reduction Coalition is one of our favorite partners. They have a ton of awesome resources for patients and for clinicians about how to have that conversation and what are those tips. I want to acknowledge that for some people, these are not comfortable conversations, and that's okay. That's okay. But our patients are dying and they're getting really sick from this. And so we have to step up and be more comfortable talking about these things that can help them to live healthy and to live well. If you forgot everything I just said, or you need access to our quick start guide, or you want that FAQ about fentanyl test strips, everything is on the California Bridge website. I will hover here for 1 second and we will take a look at the questions. For those of you who are just here for this part of the lecture, thanks for being here. And thank you for everything that you're doing to help us save lives. If you ever need help at your specific hospital, reach out to us, info@bridge2treatment.org, and we'll be here for it. Thank you. All right, let me sneak on up. Okay, so I saw there were some questions. Somebody says, do you stop giving bupe when the patient? Okay, so in the algorithm, I mentioned that you give 1 dose, you wait, you give more. Even if the patient is feeling completely all the way better, on that first day, we do recommend giving at least 1 more 8 milligram dose. And the reason is kind of like I was describing, right? The journey, the medical progression of withdrawal is a process. And so the person was in moderate to severe withdrawal. If we do nothing, that is going to progress. So we give enough buprenorphine that they feel better right now. We have to sort of assume that they may not have been done all the way down that withdrawal pathway. So we're giving at least 8 more milligrams to sort of buffer, knowing this is the first day and that their underlying withdrawal may progress a little bit. It is very safe to do. So let's say that I gave 16 up front and they feel amazing, they have 0 symptoms, I'm going to give another 8. I'm absolutely going to do that. If I gave 16 and they were starting to feel a little bit better or not that much better, I might give another 16. I might give a 3rd dose until they feel better. And then we can give that last 8 milligram dose and be done. Even if you have to give really high doses in that moment, we have some of our experts have cases where they've gone very, very high on bupe, higher than the 60s. Don't be afraid of these numbers. Again, there's no respiratory depression from this medicine all by itself. But even if you get really high in that dosing area, you can still send somebody home usually on somewhere between 16 and 32 total milligrams daily, but just write for a couple of extra strips and say, hey, if you're still having symptoms, take it again. And then let me keep looking back up. Sorry, they're all mixed in here. Will a child need to continue buprenorphine? Oh, no. A baby, I think you mean after a delivery. So it is safe for moms to be on buprenorphine or methadone. Actually, the current guidelines for babies that are born to mothers who are on MAT is to do just what is called sleep, swaddle, console. They do not do methadone or buprenorphine replacement therapy for infants. And the data is very, very good that babies do not need to be on any opioid supplementation or opioid medication or partial opioid agonist medication. They do well with just feeding, spending time with mom, being cuddled, and they do really, really well. So that's another reason that we want mom on medicine. It's so much safer than mom being on heroin or mom using fentanyl or any of that kind of stuff. So it's good for baby. Yeah, no problem. Okay, I think that was all of the questions that we had. So if you have other questions that you think of, please reach out to us, info@bridge2treatment.org. Please take a look at our resources page. We have so much more than we even covered today available to you on that website. And hopefully the new quick start guide that we just updated, hopefully it's a little bit more clear. We really appreciate the feedback that we've gotten from any of you who are using it. So if you're using it and you can think of a way that it could be better, we want to hear from you. If there are other topics, training topics that you want to see us cover, we want to hear from you too, because we will happily put together something that addresses those concerns. But I just want to say thank you again for taking the time to be here with us, and reach out if you need us. And thanks for everything that you are helping us do to get out there and save lives and help our patients to live.